Okay, hello everyone. Uh, it's my pleasure to invite you all to the first ACARE Level Up webinar. Uh, Good morning, good afternoon, or good evening to all of you, depending on your time zone. So for the webinar today, this will be moderated by myself. I'm Dr. Ankur Jindal, Assistant Professor of Pediatric Clinical Immunology and Rheumatology at Postgraduate Institute of Medical Education and Research, Chandigar, India. And with us, we have three excellent speakers. Dr. Ridhima Aggarwal, who is a fellow in Pediatric Clinical Immunology and Rheumatology with us here at Chandigarh, India. And we have Dr. Philip Lee from Hong Kong. He's an assistant professor in the Department of Clinical Immunology and Rheumatology. And Dr. Hilary Longhurst needs no introduction. She is an honorary associate professor, Auckland University, Auckland City, New Zealand. So these are the three excellent talks today. One first by Dr. Ridhima. She'll be talking about the domino effect, unearthing HAE from one to many. We'll have the second talk by Dr. Philip Lee, who will be talking about disparities. He'll be addressing these issues from the from East perspective, and then we'll have Dr. Hilary's talk about cautionary tale, and we'll have about 10 minutes of discussion, question and answer after this. The objective of this webinar today is to understand and apply cascade screening for hereditary angioedema. We understand challenges in diagnosing and treating HAE in the Asia Pacific region. How is it different and what are the potential associated with this? And we understand options for HAE prophylaxis, the risk-benefit ratio of different prophylactic options, and how to avoid, minimize the risk. And we are very fortunate to have participation from 32 different countries with 70 registrations so far. So this includes participation from South America, Australia. We have the participation from different countries in Europe. We have also participation from North America, Canada. We have participation from Africa as well, and then from Asia, different countries in Asia as well. This webinar, you'll get a CME accreditation, so you'll get 1 European CME credits, but it's important that you are there for a full 1 hour, and at the end of the webinar, you need to complete a brief feedback form to get your CME credit points. So you can access the feedback form through this link, and I'll show you this link at the end of the webinar as well. So I would request you to listen to the entire webinar, complete these feedback form, and then get your CME credits. And with this, I hand over the stage to my first presenter, Dr. Ridhima Aggarwal. She's right here with me, and she will be talking about the domino effect, unearthing one from many. Over to you, Dr. Ridhima.
So good morning, everyone. I'm Dr. Ridhima. I'm a postdoctoral fellow in Pediatric Clinical Immunology and Rheumatology from Chandigar in India. So I've called my talk today the domino effect, unearthing hereditary angioedema cases from one to many. So I have no conflict of interest or disclosures related to this presentation. So currently, the global prevalence of HAE has been labeled at 1 in 10,000 to 1 in 50,000. And considering the population of India, which is approximately 1.4 billion, logic says that we should have approximately 27,000 to 135,000 patients with HAE in India at present. However, we have currently diagnosed approximately 500 only. And this goes to show that HAE remains grossly underdiagnosed in our country. So I'm going to start by talking about this story with starting about my index case. So this is a female. She's a 21-year-old female who traveled from Jammu to our center in Chandigarh. This distance is approximately 360 kilometers, and she traveled far to be diagnosed. So she presented with recurrent episodes of angioedema during her pregnancy, and at that time she was at 9 weeks of gestation. She was referred to our clinic, and on taking history, we clinically diagnosed her with HAE and quickly performed a screen, and we found that her C4 levels were profoundly low and her C3 levels were normal. After this, we quickly proceeded to establish a genetic diagnosis for her, and we found that she had a mutation in the SERPING1 gene, which was pathogenic by the ACMG classification as well. And following this, she underwent amniocentesis at 60 minutes. Now, unfortunately, at this stage, the fetus was also found to be affected, and the parents were given a choice, and they chose to go ahead with medical termination of pregnancy. After this entire episode resolved, when we called her back to the clinic again, we had many questions to ask her. Why had she not sought treatment before? What was the reason for the delay in diagnosis? Had she had such episodes before? And while questioning her, we actually found that there were many in her village that were affected by the similar illness. The illness was, in fact, so common that most of the villagers had accepted this as a malady of the village and accepted it as a part of their lifestyle itself. And these people belong to different age groups. No one had ever been diagnosed for this. No one ever sought treatment for this illness. And many had even lost their lives due to this illness. So at this stage, we started wondering whether something bigger was going on. And we requested her that in her next medical visit, could she get a few serum samples of a few of her relatives. And when we performed the C3, C4 screen on all of those samples, we found that there was profoundly low C4 levels and normal C3 levels. So at this stage, it was clear that we as doctors had to travel to their district and actually uncover what was going on. So in March 22, we traveled to the Riyasi district of Jammu and Kashmir, where this patient was from. And this district has a population of approximately 300,000. We started collecting patients based on their clinical manifestations, and we documented their detailed clinical profiles. And in this visit, we planned to collect their samples. We stored them and transported them to our institute for analysis, including genetic tests. So this is the Riyasi district. Now, as you can see, there's something called the Panchayat. Now, this is a place where all the elders of the village sit together and make major decisions. And this is the place that they gave us to set up the medical camp. Here, patients came voluntarily to be screened, to tell us about their complaints and to be tested. And at the end of this first field visit, we found that we had approximately 24 patients that were identified. And these 24 patients were from 4 different families. Now, the testing could only be performed in 18 patients. And we found that the median age at onset was 15 years for the symptoms. But the median age at diagnosis was 33 years, with a delay in diagnosis of approximately 20 years. The male to female ratio was 2:7. And the predominant sites of involvement for HAE were the face, eyelids, lips, tongue, back, hands, feet, and genitalia. The swelling of episodes was significant. The average frequency was 2 episodes per month, and the average duration of each attack was 3 days. The prodromal symptoms varied from mild tingling to itching, pain or redness at the local site, and trauma was the most common trigger that was identified on history. And we also noted that there was a mortality of about 3 patients that was noted. Now, this is the initial data that we collected from the 24 patients, and we found that there was, along with tongue swelling and abdominal symptoms, there was a very high frequency of laryngeal edema that was noted in these patients. And the C4 level was reduced in all of these patients with the mean level of 0.058 grams per liter. C1 INH level was normal in all of the 18 patients which were tested, which made us suspect HAE type. Now, targeted next generation sequencing was done for all of these 18 patients. And to our surprise, we found that all of these patients had the exact same mutation as the one that was identified in our index case. So as I'm showing over here, this is the Sanger sequencing that has been done for our original patient, which was our index patient. And this is the sampling that has been done from a gentleman from a completely separate family, and this is from another gentleman from another family. And all of these families live in the same district. We are not able to trace back which is their common relative, but all of them have the same exact mutation, which made us believe that this is probably a founder mutation affecting the people in this district in Jammu. At this point, I'll take a little bit of time to talk about cascade screening. Now, cascade screening is where you identify an index patient and you start identifying the next of kin and all the at-risk relatives, and then begin screening them. This is a very valid screening program that is mostly applied to autosomal dominant disorders. And as more relatives are screened, more at-risk relatives are identified. And then this process just keeps on repeating or is cascaded until no other family members can then be traced. So by cascade screening in our first visit, so this is family number 1, we identified a female that was affected. And by cascade screening, we found that her sister was affected, mother was affected. We screened the mother's sister, even though she was not symptomatic at this stage. And we found another sister of the mother, which was affected. So we found a family which had 5 affected patients by cascade screening. In family number 2, we started with a gentleman, and unfortunately, as you can see, his father and all of their siblings had lost their lives, likely due to this illness. So we continued to screen all of their children, even though they were asymptomatic. And we found that this gentleman had a sister which was affected, and she was tested. Family number 3, we identified a female whose both children were affected. She had lost a brother, so we tried to screen their children. And family number 4, this is the largest family that we've identified over here. And this is also the family her index case belongs to. And you can see over here, she has multiple siblings which are affected, her parents, her grandparents, multiple grandparents are affected, multiple first line cousins are affected. And we are trying to screen all of their second and third generation relatives right now. So at the end of our first visit, from our index case, we identified 14 more affected members of the same family. So we felt very happy at the end of our first field visit that we have found so many more patients, and now we can initiate therapy in them. And we initiated long-term prophylaxis in a lot of them in the form of tranexamic acid and danazolol. But at this point, we stopped and we asked ourselves, has our final goal actually been achieved? So after 3 months, when we contacted the patients, unfortunately, to our disappointment, we found that despite diagnosing these patients and despite prescribing them the medications, none of them were actually taking the medications because affordability was an issue. Many patients did not even understand the gravity of the disease. Most of the patients had already accepted this disease as a part of their routine lifestyle. They did not see any significant benefit with taking the drug. And most of the patients would only take the drug when they would have an attack. And most importantly, they felt that there was no doctor to approach at the time of an episode. So when we contacted the local doctors over there, to our surprise, the doctors said that we have no patients of HAE, and where are these patients of HAE, and why are these patients not reaching out to us? And at this point, we realized that just screening and identifying patients is not enough. We need to bridge the gap between a patient and a doctor. And this is when we did our second visit to Jammu. This time we called all of the patients en masse to the local hospital. We conducted an OPD. We registered these patients in their local OPD, identified point of care doctors, introduced them to the patients, exchanged phone numbers, and made the patients feel comfortable in their presence so they could contact these doctors in case of attacks. In the afternoon, we also conducted a CME with all these doctors. It was attended by senior and junior faculty from departments of medicine, pediatric, dermatology, and ENT surgeons. And we had a very fruitful discussion about how to diagnose, how to approach HAE, what are the methods to screen, what are the clinical features, and what treatment options. Fortunately, at this time, plasma-derived C1INH was available in the Indian market, so we could even discuss how to provide this therapy for on-demand therapy for our patients through government supply, how to make long-term prophylaxis available to these patients free of cost, and what are the measures and what are the ways we should motivate these patients to remain in regular follow-up. So in our second cascade screening, we see that initially the patients who were asymptomatic were now diagnosed as HAE. One unfortunately lost her life, and performing cascade screen downstream, we found another affected patient. This is the largest family family, again, which we have, these 3 patients were asymptomatic when screened, but found to be affected. And there's an expansion of this family. And now we have a total of 29 patients affected in the same family. And we found a new family, which was identified with 7 more patients affected in this family in the same district itself. So talking about cascade screening, it's very relevant to hereditary angioedema. This paper shows that out of 179 relatives who were found for all the HAE patients, 53% were contactable and only 67% consented to screening. But the most important message that this paper gives is that half of the patients who were screened were even asymptomatic at baseline. And we've been able to probably diagnose them earlier and give them a diagnosis earlier so that they know that they are at risk of developing attacks in the future. So similarly, in our case, from 1 patient, we first diagnosed 14 more patients, and then again, we diagnosed another 14 patients, so total of 28 patients from the same family. And probably every time we go, we will diagnose more and more patients from the same family. And most importantly, we have identified 5 asymptomatic individuals. We feel comfortable and very happy because 3 out of those 5 are children. And now the parents know that these children are also at risk and will be more careful in managing their attacks as well. So this is the final clinical profile that we have from the patients from the Riyasi district. The swelling of extremities, abdominal attacks, and facial swellings tend to be more common. Laryngeal attacks are very high in frequency, but less common. And we're beginning to identify patterns for them. Triggers, the most common trigger still tends to be trauma. So if we look at the HAE prevalence, in our first visit, we were hitting a prevalence of approximately 1 in 125,000. Our first cascade screen led us to reach a prevalence of almost 1 in 10,000. And now after our cascade screen number 2, our prevalence is almost at 1 in 7,700. So yes, we definitely have achieved the target of 1 in 10,000, 1 in 50,000 in this district. But I can say for sure that probably the prevalence in this district is much, much higher because we have not even completed our cascade screening of 3rd and 4th generation. These families are huge and require further screening to actually know the total prevalence in this district. So with this, I'd like to end my presentation. I'd just like to say that cascade screening is an effective approach to family screening in HAE, and screening patients is not enough. It must be followed by trusted and easy access to a physician that is aware about HAE for effective disease monitoring and therapy. And socioeconomic status and patient education play an extremely important role in increasing compliance to medication. So thank you, and I'd be happy to take any questions at the end of the session. Thank you very much.
Okay, thank you, Ridhima, for your excellent talk, and the messages are very clear. The challenges that are faced by physicians as well as by patients from the developing countries, and I think to continue the same idea, we will have another talk by Dr. Philip Lee from Hong Kong, and we'll be talking about, in general, challenges that the doctors and patients face while diagnosing and managing these patients in Asia Pacific region. Dr. Philip Lee, as I already introduced, he's an associate professor in Department of Clinical Immunology and Rheumatology at Hong Kong. He unfortunately is unable to join us in person, but we will have his recorded presentation now. And most likely he'll be able to join us by the end of this session. So he'll be available with us for the Q&A session. So may we have his recorded presentation material?
Hello, I'm Philip from Hong Kong, and thank you for the opportunity to present to you about HAE in the East, addressing disparities in diagnosis and management. Here are my conflicts of interest disclosures, none of which pertain to today's talk. So, we've always been told that HAE in the East is rare. What do we mean by in the East though? Today, I'll say East means the Asia Pacific region, where it represents about half of the world's population. And although it does consist of half the world, it does seem on paper that the prevalence of HAE seems to be lower in this part of the world. However, I would argue that it's not because HAE is rare, it's just rarely diagnosed. Here is an example of how HAE is like in the East. So, unfortunately, some cases like this can still exist today. So, this is a 37-year-old male who apparently had good past health and presented with a long-standing half-a-day history of very severe abdominal pain and vomiting. On physical exam, he had a very grossly distended abdomen with absent bowel sounds. His chest X-ray here shows very dilated large bowel, and actually a barium enema diagnosed and confirmed obstruction at the splenic flexure. So he had to undergo an emergency laparotomy and was performed with a large bowel obstruction seen intraoperatively, and thereafter 90 centimeters of the colon was excised. So here is a photo of the grossly discharged large intestines, and you can see the excised colon here too. So this is a very unfortunate case because actually, on retrospect, the patient had already for many years sought medical attention and also tried to find out why he had these many episodes of spontaneous swelling in his limbs, genitalia, without associated wheals or rash. He never used any ACE inhibitors. And in fact, this problem of swelling ran in his father's side. Some paternal relatives also had these swellings. Here is his paternal cousin. She also has spontaneous swelling of the limbs, face, and also abdominal pains. And you can see here gross asymmetrical swelling of the hands, which occurred very frequently, but without a diagnosis throughout the entire family. So we worked up this patient, and very classically for this patient now having undergone colectomy, had an absent C4, very low C1 esterase inhibitor level, and subsequently SERPING1 genotyping confirmed a pathogenic mutation. Because of the lack of other alternatives, he was started on Danazol, but unfortunately, because there was no other treatment available, finally he came to us and we got icatibant, and he started him on icatibant, and we are now performing family screening. He's very happy and flies frequently to Hong Kong for a confirmatory sort of diagnosis as well as a subsequent follow-up, and we published his case recently in the NAJM. But this just shows that how after so many years of understanding HAE with so many medications now available, something like this can still happen in our side of the world. So compared to the West, HAE in the East is very different. When I was in med school, I actually was never taught this disease. You say HAE, many of my colleagues or my fellow physicians or healthcare professionals who have never have heard of this condition. Because of this lack of awareness, there's very little efficacy for the very rare individuals with HAE. And even if you could find these patients, no one can follow them up or offer care because there's such a shortage of immunologists, lack of referral pathways, and no diagnostic tests available in many of the regions in our part of the world. Even after tests, you can get it somewhere else, but where the medications, even when the medications are registered, which they seldom are, they aren't affordable, and we participate in very few clinical trials. I'll come to that later. So we conducted this study a few years ago, and we did a survey of the countries representing the Asia Pacific. And we understand that we have disproportionately low prevalence and about 0.04 per 100,000 compared to the West, which is many times higher. Interestingly though, even among regions with very similar genetic backgrounds, we see that the prevalence can vastly differ, and therefore postulate really isn't about a genuine biological difference between different ethnicities. It's more about the ability or the facilities to do diagnosis. We also found that in many countries, there are many disparities in testing. In fact, only about 60-70% of countries surveyed really had access to C1 esterase inhibitor testing. And we found that if you have tests available, you're better off at diagnosing patients earlier. Treatment is also a problem. In fact, only half of the countries which we were surveying had access to on-demand HAE medications, and even fewer for prophylaxis. We found out that if you have regional guidelines and also patient support groups, your chances of the country in Asia Pacific region having access or treatments will be much better. But then again, this is something we're working on, but still far compared to the West. And beyond just awareness, diagnosis, and treatment, another issue is the disparities in clinical trials between the East and the West. We all know that we really need good clinical trials in order to prove treatment safety, efficacy, and ultimately become registered in many parts of the world, especially in the countries which had the clinical trials run. And we hear that in the West, many countries find it hard to recruit patients, especially for on-demand therapies, because patients are already so well treated and patients are sometimes unwilling to be recruited in these clinical trials. But this is a very sad comparison. We're putting patients in the East as a comparison. So in our recently collaborative research study, this is still unpublished, so we actually know that there's a huge difference between the participation in Eastern versus Western countries, especially among different races. So you can see in total over the past 20 years, the vast majority of countries involved in clinical trials has been predominantly been European or from North America. Other continents represent a minority, and I highlight here Asia. Okay, we've had very good improvements. You see that in 2003 to 2010, Asia countries participated in about 16% of all clinical trials, which have vastly improved up to 61.5% in the recent decade or so. But look at the ethnicities, the race of the participants in these clinical trials. White patients contribute 88% of all clinical trial participants from the past 20 years, whilst other ethnicities are very drastically underrepresented. I again highlight East Asians. Asians only participate or only contribute to 7% of all clinical trials, although yes, with a significant improvement from 1.4 to 7.8% in the past 10 years or so, but still a far cry from anything near what we feel the true prevalence or share of disease burden is. Looking aside, here are all the continents and different countries from 2003 and 2010 participating in HAE clinical trials. These countries, especially in the West, have flourished, and you see the darker the blue, the more clinical trials that have been participating in the past 10 years. North America, Europe, especially countries like Germany and also the US have really improved. Asia has also improved. You can see China, Japan, some countries are really also improving in terms of participation. But again, still far off from the West, and look at other continents, very, very underrepresented, especially Africa and South America. But not all is sad. We have actually been improving, and I'm happy to say that with a lot of collaborative efforts in the East, we are making strides to improve. For example, in awareness and diagnosis, in fact, Hong Kong, we did something quite novel. We call it a cascade family screening. It's been used in many different autosomal dominant disorders, where although we do recommend screening primary or close family relatives for if they harbor other SERPING1 or for screening for HAE. In fact, in our experience, many people are not able to convince their nuclear family or their close relatives to come. Cascade family screening means if you do fail to get that next family member in, do not give up. We cascade it down to the next. So we assume that person who declined family screening may have had HAE, and we then screen the offspring or the relatives, for example, the siblings of that particular patient. And we've shown that it has really, really good effectiveness, especially among Chinese families. You see that no matter who we screen, no matter they were asymptomatic or symptomatic, we drastically improve the number of attacks or future attacks, as well as the attack-free rates. The cost saved, no matter, again, symptomatic or asymptomatic patients or relatives, drastically improved. And also, more importantly, probably, is the mental health or the non-physical aspects of HAE and effects on health-related quality of life. They all significantly improved. So another side product of this project we did was, in fact, through cascade family screening, we were able to vastly improve the diagnostic and prevalence rate of Hong Kong from 0.16 per 100,000 to 0.6 per 100,000 in a very short span of around 1 year. And now we are trying to implement this in other Asian countries. We've also been working to improve testing. Unfortunately, Asia is a very big continent, countries are very big. Places like China and India sometimes do find it difficult to get blood to certain labs to do testing. One particular problem is HAE type 2, where I'm sure we all know that the functional testing for C1 can be difficult and very time dependent. You need to process the blood quickly and get it to the lab. And therefore, C1 inhibitor function has been quite prohibitive because of the lack of access in these big countries. Luckily, together with India, Professor Ankur Jindal, we've been able to work on this, and we now have proven that even if you don't have C1 inhibitor level function, you're able to substitute this, or at least as an initial screening tool, find if the patient has an absent C4 and a contradictory or probably a counter increased C1 inhibitor level. It's actually a good screening test, and we coined this a poor man's C1 inhibitor function. And you see the area under curve is very good. It has very good performance, and we're able to use this screening for type 2 HAE using the low or absent C4 with an elevated or high C1 inhibitor level. Furthermore, we've also in the past few years been trying harder to get into clinical trials. And we're happy to say that, for example, in our center, we've been able to be lucky enough to participate in some trials, as well as having some compassionate use of prophylaxis. And we were actually the first to report long-term prophylaxis data in Chinese HAE patients, showing that the use of GARA and LANA in our population is equally as effective, no matter in attacks, quality of life, treatment symptoms, etc. And therefore, we hope to advocate for more participation in clinical trials in our populations of the East. Also, similarly, in China, especially across the harbor from us, we are now making our own regional guidelines, knowing that guidelines can actually improve treatment access and diagnosis facilities in the long run. Hong Kong and Macau now have our own severe hives and angioedema referral pathway to advocate for severe CSU, rarer conditions like HAE, and more importantly, to identify and differentiate between them. We're now advocating, and hopefully more HAE treatments can be available. Last but not least is the improving collaboration across different teams across the world. Here, again, an unpublished data set, we did a bibliometric analysis of all of the HAE clinical trials throughout the past few years. You can see that the HAE research has increased tremendously within the past 10 or 20 years or so. The graph on the right shows, with the lines intertwining between different countries, the sort of affiliations and collaborations has been happening across these different countries. And if you look and it cuts the time frame for the past decades, you can see that in the 1970s to 2000s, there was very little collaboration. The US did its own thing, the European countries had some collaborations, and the rest of the world pretty much not started yet. Throughout the years since the 2000s, you see a lot of cross collaboration over between the United States and other American continents as well as Europe, but unfortunately not much collaboration to the east. But I'm happy to say, really, in the past decade, the story has changed. No longer are individual countries working hard for their own patients, but cross collaborations have been very, very international and very productive. And you see the many lines of collaboration in this graph here. So in summary, I really feel that HAE does not discriminate against race or geography. And I'm hoping that's the case that we presented does highlight an urgent need for an international collaboration to help other HAE patients across the world. In 2024, we hope that HAE care, diagnosis, treatment can be equal, global, and no longer any disparities. It's important to develop regional and global HAE communities, and we are now starting in the East. And we're happy to announce that under ACARE, we now have a new initiative, the HAE Asia. Asia stands for Angioedema Screening in Asia. And I hope that by increasing awareness Along with experts like you all here today, we can really help and strive for a better future for HAE patients all around the world. I thank you for your attention, and we'll take questions, and I hope we have a fruitful discussion. Thank you.
Thank you, Phil, for bringing this perspective to the HAE community. And we hope to see you live after this talk for taking up questions related to your talk. So we have this last presentation today by Dr. Hilary, and she's going to talk about a cautionary tale. And we look forward to your presentation, Dr. Hilary.
Thank you very much for that kind introduction. I'm Hilary Longhurst from Auckland, and I'm actually going to share a historical tale that I'm afraid is still relevant to all of us, and we learned a lot of lessons from this poor lady's case. Here are my disclosures. And my patient is Ms. X, who was born in 1974. And actually very young, she began to have hand and feet swelling and also episodes of abdominal pain and vomiting. And we know that the earlier the onset of symptoms, the more likely, the more severe HAE is likely to be in the long term. She had hospital admissions from the age of 3, and in 1978, she was admitted to hospital with severe facial angioedema and abdominal pain. And at that time, she was diagnosed with hereditary angioedema on the basis of low C4, normal C3, and low C1 inhibitor protein. It wasn't necessary to make the diagnosis to test her C1 inhibitor function or to do her genetics, and they weren't done at that time. So when you diagnose someone with hereditary angioedema, there are two main therapeutic things we consider. The first for everyone is how will we treat that acute attack? And then for some people who have frequent attacks, we may need to consider whether prophylaxis is necessary and what to use. So as everyone I expect knows, C1 inhibitor deficiency, hereditary angioedema, is caused by an excess of bradykinin and overactivation of this factor 12 kallikrein contact pathway, which is normally regulated by C1 inhibitor. So when we treat an acute attack, we can either give C1 inhibitor replacement, or we can block the bradykinin receptor by giving icatibant. And the advantage of icatibant is that it's self-administered. And if we live in the States, we may have access to ecallantide, which is a kallikrein inhibitor, which also is effective. Unfortunately, in New Zealand, in the 1970s, we didn't have any of this treatment. I don't think anyone did. So this patient was treated symptomatically. And for severe attacks, she was given fresh frozen plasma. And we know that fresh frozen plasma contains C1 inhibitor, 1 unit in 1 ml, and that it can be effective, although its safety margin is obviously not nearly as good as C1 inhibitor itself. And what happened in this situation was most of this child's attacks were untreated. And looking back over the years, it's really it was a very sad work for me to look at this, because over the years she had multiple hospital admissions. Each one tended to last a week or sometimes even longer, and comprised vomiting, abdominal pain. She was often dehydrated. On 2 occasions she had surgery. She had her appendix out and a laparotomy, both of which turned out to be unnecessary, much like Philip's patient. And she had many erroneous diagnoses, including lymphedema, when she had a very severe leg swelling on 1 occasion. And also coming through the letters, you can see that she was beginning to have very significant interruption to her education. And also having a child this sick caused a lot of stress, not just on the child, but on the family. And there was the beginnings of some quite significant family strife. So we see again and again with hereditary angioedema, the physical symptoms cause psychological and economic symptoms, which then, since stress tends to lower the threshold for attacks, causes more physical symptoms. So my patient was having very frequent attacks, hospital admissions, and so we needed to consider prophylaxis, which we could do with either subcutaneous C1 inhibitor replacement, not available at that time and still not universally available in New Zealand. We could inhibit kallikrein with lanadelumab, a monoclonal antibody, or with berotralstat, an oral small molecule tablet. And all of these are first-line treatments. Unfortunately, our patient didn't have access to these treatments. So then we had the choice of second-line treatments, attenuated androgens, danazol, or tranexamic acid. Tranexamic acid was not helpful. She continued to have life-threatening laryngeal attacks and admissions to hospital because of this. So age 16 in 1991, she started daily danazol treatment. And if you just look at the lower left hand of this slide, you can see this is a small but very elegant study which shows that in a double-blind placebo-controlled crossover, danazol was extremely effective in preventing angioedema. The problem was that the dose that was used was 600 milligrams a day. So this is what most of us would consider an extremely high dose. We also know that methyl testosterone is effective, although we wouldn't normally give that to people because of its poor safety profile. It's not attenuated. And we also know that only 17 alpha alkylated androgens are effective. And there's case report evidence for lower dose danazol, 100 to 200 milligrams daily, which normally would be our upper dose, as well as other attenuated androgens, which I think are a little bit better tolerated, including stanozolol, oxandrolone, and tibolone. And you can see in this observational study, if you look at the top right here, that a large number of patients on danazol, and these were patients, the vast majority of whom were taking less than 200 milligrams a day. You can see that most of them had a very significant reduction, 91 to 100% in frequency of attacks. But there were some people at the other end who experienced almost no benefit. Unfortunately, the efficacy is dose-related, but so are the side effects. And in the same study, in fact, and another study by Sicardi, the main side effects were enumerated, and these are mainly anabolic, so weight gain, hypertension, hypercholesterolemia, and androgenic, so particularly devastating for a woman, amenorrhea, hair growth, deepening the voice, and mood changes. And specific to the 17-alpha alkylation, in higher doses particular, it can be hepatotoxic, and in long-term, particularly higher dose use, but at any dose, adenomas can form, which if left can cause liver rupture or can turn malignant. Now, our patient was said to be better on danazol, but she was on a massive dose, and she experienced many side effects, which you can see here. Over the next few years, she continued to have very frequent abdominal attacks. She probably also had peripheral attacks, but I think these were overlooked both by our patient and the doctors. And she continued to have frequent hospital admissions. She had a cholecystectomy. She had an episode of pancreatitis, possibly related to obstruction of the pancreatic duct by angioedema. And she had multiple gut and other investigations looking for other causes other than angioedema of her symptoms. She did have some upper airway swellings and had to be on the high dependency unit, but was never intubated. And she did experience some inappropriate treatments, being treated with adrenaline and antihistamines on a few occasions, despite the fact that we know they're not effective. And as time went on, you could see that she was which she was taking on other problems other than the physical problem. She had some episodes of pseudoangioedema where she would perceive symptoms as angioedema and have hospital admissions, even though there was no objective evidence. She did, of course, have real angioedema as well. She developed chronic abdominal pain with exacerbations, and this is quite common in my patients who have frequent undertreated or untreated C1 inhibitor deficiency. She developed migraine, which may have been stress related, may have been dehydration related, or may have been intracerebral angioedema, possibly. She had high ongoing use of opioid analgesia and antiemetics, used to treat her symptoms, but also used quite frequently in between. And she was subject to a lot of, at the time, a lot of beliefs. So even in published papers at the time, there was a thought that C1 inhibitor wouldn't alleviate bowel angioedema. The reason for this in our patient's case was probably because she was given a lower than optimum dose for her weight, and it was usually delayed a day or more while other ineffective treatments were worked. She developed very poor venous access, and even to this day requires ultrasound to access her veins. She learned to be afraid of going to the dentist because of dental work triggering attacks, and she had very poor dentition, poor gums, and required more invasive dental surgery. And she was referred to the psychologist, who, not surprisingly, diagnosed depression and anxiety, as is the case with so many of our patients. So by the time she's an adult, she's continuing on this high-dose danazol, which is clearly not effective. And she can't get peripheral venous access anymore, but continues to have recurrent symptoms. She was referred for IVF, but was unable to progress this because she couldn't come off danazol and wasn't ovulating, and this led to more family strife. Worst of all, her education had been interrupted. She hadn't been able to complete it, and she hadn't been able to work in a regular job for about 20 years. In 2018, she was invited to join a clinical trial of berotralstat, but unfortunately she couldn't tolerate being off danazol. She was admitted within a few days with a severe abdominal attack. And in 2019, an indwelling port was inserted because venous access was no longer possible in the emergency room. Now, just to move aside here, this is an internet survey done a few years ago, about 10 years ago. And what this survey showed was what those of us who'd used ports had learned the hard way. We found that a very high proportion using ports to access C1 inhibitor experienced a significant thromboembolic episode. Not to mention the people who got colonization or infection of the ports, and both thrombosis and infection will themselves trigger HAE, leading to a vicious circle of more HAE attacks, requiring more C1 inhibitor. And this is just to show you our patient in due course developed a very extensive thrombosis, which was treated with long-term anticoagulants. So what were we going to do? Well, by this time, elsewhere, highly effective prophylactic treatments were available, and we considered subcutaneous C1 inhibitor. Now, if you look on the graph on the right, you can see that if you can get your C1 inhibitor function up above 40%, we know that the frequency of attacks will be dramatically less. If you look at the red zigzag line, this is what happens when you give twice weekly C1 inhibitor. About 50% of the time, the C1 levels will be below that magic 40%. So although you will have a reduction in attack frequency, attacks will still happen. You can get the levels more easily above this magic level of 40% by subcutaneous C1 inhibitor, shown here in the blue, but you require higher doses, and this was not available to us at the moment, at that time. So initially, as a holding measure, we taught her to self-administer Berinert. Unfortunately, it wasn't possible to teach her to self-administer peripherally because she had no venous access. So she self-administered via the port on a daily basis, and then was able to change to twice the dose every second day, and was able to maintain her C1 inhibitor function within the low normal level. And at this level, she had no attacks, and she returned to work for the first time in 20 years. But clearly, this is not a long-term solution. And sure enough, in November that year, she developed fevers, more abdominal pain, and she developed a port infection. The port was taken out. She was given interim antibiotics and was replaced. Meanwhile, we applied for her to have lanadelumab, a kallikrein monoclonal inhibitor that we know is incredibly effective at preventing attacks. On lanadelumab, she has had no attacks requiring emergency room treatment. She's been able to stop stanozolol, and she's got promotion at work. And we've been able to remove that port, which was so risky for her. So what have we learned? Well, acute attacks need rapid, effective treatment, ideally with first-line agents or FFP if they're not available. I wish that we'd been able to teach this lady when she was a teenager to self-administer C1 inhibitor because that would have preserved her veins, and although she might have used quite a lot of C1 inhibitor, it would have enabled her to have a nearer normal quality of life. We should never put ports to administer C1 inhibitor, although sometimes our choices are very, very limited. And with modern prophylaxis, we can provide almost complete attack control, and we can normalize lives so people don't have to have intravenous C1 inhibitor or become medicalized in the way that our patient was. And most importantly, uncontrolled HAE, it's a huge hidden detriment on people's general health and on their families' health. These patients are not popular with their doctors because, of course, we're not giving them the treatment they need. So we in APAC need to work towards access to modern HAE drugs for everyone. Thank you.
Thank you, Dr. Hilary. It was very informative and good learning exercise. I think we to all the participants, I think we can start putting up questions in the Q&A box or in the chat box. Philip is also with us now online. We just have one question or maybe comment from Connie. Philip, I'll read it for you. I think it's for you. It's about your presentation. So there are many reasons for non-participation of members of other ethnic backgrounds, and these include socioeconomic problems that inhibit taking time off work to participate in trials. There are also cultural factors where some are reluctant to be involved in experimental treatments. So it is not always lack of opportunity, but the other factors that provide a hindrance for involvement of patients into clinical trials in these areas. Would you like to add comment? Yes.
I completely agree, Connie and Ankur, that I really believe that there are so many factors. But I think the story is, no matter how we see it, is that it's a vicious cycle. So underprivileged patients, no matter where they work, I think suffer. But especially from in countries where they're already suffering a lot more. So HAE patients in the East do not get the care they need. They are even more disadvantaged at work, and therefore they are at an even greater chance of not being able to participate. I think it's a universal problem, and I agree that some of the factors that lead to disparities in clinical trial participation may be more than just the pure unfairness in recruitment. But I think the underlying issue is, and the overall message needs to improve the care for all patients. And I think by doing that, all of us will slowly fill the gap and will pull and mend the sort of barriers in the East and the West. Thank you.
Thank you, Phil. I don't see any other questions or comments in the chat box or Q&A. So, I mean, just to initiate the discussion, maybe I have a couple of questions. I'll start with Dr. Hilary. So, Dr. Hilary, I mean, this is a challenging case, such a long history. And I think this is the scenario that exists in Asia Pacific countries, most of the Asia Pacific countries. Now, in terms of long-term prophylaxis, in India, we only have intravenous plasma-derived C1 inhibitor concentrate, and I think that's the scenario in few other countries as well. What if a patient needs long-term prophylaxis with the intravenous plasma-derived C1 inhibitor concentrate? What would have been your approach? Like, would you consider giving them with Pamacat, or what has been your advice in these cases?
Yes, so the optimum would be to train that patient to insert a butterfly needle into their own vein or a close family member, and train them to make up and administer that C1 inhibitor. And when you do that, that patient becomes an expert in their own veins, and they tend to use just one or two veins, and those particular veins get slightly fibrosed and form their own port, and they don't tend to lose that vein. They do tend to protect the vein and only allow healthcare workers to use other veins, however, which is very wise. If that's not possible, then I do have people come to the hospital, but I try and get a situation where the patient is not going to the emergency room, but they're coming in a controlled way, where they will see a small number of healthcare workers who actually know them, know their veins, and who are expert in accessing those veins, so that you never get into the situation where you need the port. I've almost universally had very bad experiences when I've put ports into people with HAE.
Thank you, Dr. Hilary, for taking this up. And do you think that, because these patients may have a tendency to develop thrombosis because of the coagulation pathway abnormalities, and that's why they're more prone to develop thrombosis at the site where Pamacat is inserted, or is it because of the use of C1 inhibitor injection? What do you think it is?
I think this is a very controversial question, because it's hard to see how someone with hereditary angioedema, if you consider Virchow's triad, so flow abnormalities, changes in the constitution of the blood, etc., it's hard to see how HA does not predispose to thrombosis just by itself without a port. But certainly the risk seems to be relatively, surprisingly small if it exists at all. I think when you put a port in, you've got a plastic surface and you've got very high concentrations of C1 inhibitor. So it is a slightly artificial situation. And I think that's the reason. I think it's very high concentrations with, a precipitating factor. And if you get colonization, or if you get sort of microinfection, then you've got yet another factor which will lower the threshold for thrombosis to happen.
Okay, thank you, Dr. Hilary. And since I see no question, still no question, I would request everyone to ask anything related to these subjects. But in the meantime, I'll ask Philip one question. Philip, you mentioned about HAE Asia in your presentation. Would you elaborate a little bit on this? And it's my pleasure to be part of this HAE Asia initiative. But would you just for the participants, would you like to elaborate a little bit on this?
Sure, Ankur, I'm sure you're in a better position to speak to it than I am. I think it's a group effort. What we were seeing is, especially in Asia Pacific, is a very large area. We house most of the world's population, but there are some countries which do very well and some countries which aren't doing so well. And I think Hilary's case was very enlightening. You can see the different phases of change in the patient's journey from use of intravenous to prophylaxis, and we see different countries are in different strides. So some countries, for example, Japan, are very advanced, where they have all of the medications available, but there are some countries and regions in our part of the world which really struggle. We're not even finding our first patients, for example. So we really wanted to sort of have an alliance together, especially bonding with these regions where we're still struggling to identify patients, so-called the low-hanging fruits, because we know that in order to advocate further, to really take the first step, I think the footwork is really to find the first few patients, do the family screening, and get people aware that this country needs these patients, and therefore it puts together this small alliance of HA experts and interest groups sort of for angioedema screening in Asia, and we really hope it can extend this sort of ideal and this sort of motivation and put our heads together to really do a better good. And I'm really grateful for people like you, Ankur, and all our partners in this sort of region that are working together. And we really feel it's not just Asia. Hopefully in the future, beyond this year and later, the whole world can feel HAE is a community and international effort rather than just focusing on their individual patients in their own countries. Thank you.
Thank you, Phil. And I think this initiative is definitely going to bring something interesting. We're looking forward to it. I still see no more questions. So maybe I'll ask last question from Dr. Ridhima. Maybe you can just elaborate upon the availability and access to treatment for your patients with HAE in India. And you've been part of the consensus statement that was published from India. So what has been unique about that consensus?
Thank you very much, sir. So basically, talking about the residents of the Raisi district in Jammu, so that's a very isolated area, and the general socioeconomic status is lower socioeconomic status. So they definitely cannot afford plasma-derived C1INH, even though it is available. But I think tranexamic acid and danazolol as long-term prophylaxis, we are trying to provide that to those patients. Now, even something as simple as danazolol or even tranexamic acid is difficult for them to afford on a daily basis. So if you consider each family has at least 3 to 4 members which are affected, so having a monthly supply does take out quite a large amount of money from their daily wages, and it does become difficult for them to afford even that. So they definitely do need support from the government, even for the basic long-term prophylaxis that we are providing them. Other than that, I think the patients that we see in our clinic, which are more affluential or whom can afford their therapy, we have started advising plasma-derived C1INH as on-demand therapy for sure, and for patients that can afford even for long-term therapy, although subcutaneous is not available, but yes, IV we are beginning to advise. And few of our patients are even getting it from rare disease policies. So the government is supporting patients. We are registering patients and sending petitions to the government that these patients require C1INH. So currently, a few of our patients are registered with the government, and every month they get 1 unit of 500 units of the one bottle of plasma-derived C1INH, which has 500 international units. And we give it to the patients, and we are currently telling them to keep it with them, and we are educating them on how to use it for on-demand therapy.
Thank you, Ridhima. So the management, I think the diagnosis is one challenge that has been elaborated in this presentation, and management is another challenge, having better access to treatment and easy access that these patients can actually access treatment, especially on-demand home treatment for most of these patients. So this is something which is being taken up in many Asian countries, and this collaboration is, as has been mentioned by Dr. Philip, is definitely going to improve the care of these patients in Asia Pacific region. So I think I still see no more questions or comments. So we are, I think, we will overshot the time. So I'll just take this opportunity to say thanks to everyone for joining this webinar, HAE Case Reports Discussion from Diagnosis to Treatment, and to all the 3 speakers who for delivering these excellent and informative talks. I see something. Okay, so this is just thank you for the excellent talks from Joe. So this is the, because as I mentioned in the beginning, we have you to get your one CME point, you need to scan this barcode and fill up the brief feedback form. And I would request you to complete this so to get your one CME point for this webinar. So you can just stay connected and get more updates on social media and websites. So with this, I wish to thank ACARE team for giving us the opportunity to organize this webinar. The background support that has been provided by Rebecca, Vito, Materia, everyone. Big thanks to our sponsors who, without their support, I think this is not possible to organize these webinars. And thank you everyone for your participation. And we look forward to seeing you in the next webinar of ACARE, which is going to be held in February. Until that, thank you and stay safe.